All right, future IBCLCs, welcome. Let's talk about a topic that I know can feel a little heavy when you're studying for the exam, anticoagulants. So today we're going to break down exactly what you need to know. The goal? For you to walk into that exam feeling totally confident and, even more importantly, ready to support your clients safely.
So picture this. This isn't just a test question, right? This is a real-world scenario you are absolutely going to see. A parent's health is on the line. Their breastfeeding goals are hanging in the balance. And guess who they're going to look to? You. They need clear, evidence-based guidance. So let's dive in and build that foundation so you're ready.
Here's our game plan. First, we're going to get into the fundamental rules of how drugs actually get into breast milk. Then we'll take those rules and apply them to the classic anticoagulants, like Warfarin and Heparin. After that, we'll tackle the newer drugs, the so-called DOACs. And finally, we'll boil it all down to the clinical bottom line that you can take with you. Okay, so here is the secret to totally mastering this topic for the exam. You do not need to memorize a gigantic list of drugs. Seriously, if you can just get a handle on a few key principles, what I like to call the rules of the game, you'll be able to figure out almost any medication that comes your way. This is the bedrock for everything else we're going to talk about.
First rule up is molecular weight. And really, it just comes down to one thing: size. I want you to think of the gateways into breast milk as these tiny, tiny keyholes. Now, a small drug molecule, it can slip right through, no problem. But a drug with a really high molecular weight, like heparin, well, that's like trying to shove a giant beach ball through that keyhole. It's just physically too big to get into the milk in any real amount.
Okay, next, let's talk about protein binding. Picture the drug molecules floating around in the parent's bloodstream. Some are floating free, but a lot of them get kind of handcuffed to big proteins that are also in the blood. And here's the key. Only the free, unbound drug can actually make the journey into the milk. So, if a drug is highly protein-bound, it's basically locked up in the plasma, keeping it away from the baby.
Now, this next one is so important because it's all about the baby side of the equation. Let's say a tiny little bit of a drug does get into the milk. We still have to ask, can the baby's body even do anything with it? Oral bioavailability tells us how much of that drug actually gets absorbed from the gut into the bloodstream. So if a drug has poor oral bioavailability, the baby's stomach just won't absorb it and it passes right on through. So these principles give us this perfect profile, right? The ideal, safest drug to use during lactation. We're looking for something that's big, something that's highly protein-bound, and something with poor oral bioavailability for the infant. We also like a short half-life. And then we have the ultimate bottom line number, the relative infant dose, or RID. This tells us the dose the baby gets as a percentage of the mom's dose. And the magic number, the gold standard for safety, is an RID of less than 10%. This checklist right here, this is your key.
All right, now that we've got the rules down, let's put them into practice. Let's start with the classic anticoagulants, the ones that have been around for a long time. You're about to see exactly why they're considered so safe for breastfeeding families.
So heparins, and that includes the low molecular weight heparins, are the perfect first example. Why are they so safe? Two big reasons. First, remember that beach ball? Their molecular weight is huge, so they just can't cross into the milk. And second, they have pretty much zero oral bioavailability. So even if a teeny tiny bit got in, the baby couldn't absorb it. It's like a powerful double layer of safety. And then we have warfarin. For years, there was this kind of urban legend that it was unsafe, but the evidence is just overwhelmingly clear. As this quote says, warfarin's safety comes from a different rule. It is extremely highly protein-bound. Those handcuffs are on tight. This keeps it locked in the maternal plasma, and we have literally decades of use showing it's safe. And when we say undetectable, we're not just being theoretical. When researchers have actually taken blood samples from breastfed babies whose mothers were on warfarin, they found nothing. It was literally undetectable. Get this, there was even one case where a mom accidentally took 5 times her prescribed dose for a whole week, and her breastfed babies showed absolutely no adverse effects. Okay, so now we're going to shift gears from the well-established classics to the newer kids on the block, the direct oral anticoagulants, or DOACs. You're going to see these more and more, so you really need to know them. But the lactation data is a lot more recent, and it's a bit more of a complex picture. This table right here is basically your cheat sheet for the DOACs. So let's walk through it using our rules. Look at Dabigatran. It's considered usable because of that poor oral bioavailability we just talked about. Now look at Rivaroxaban. Check out its relative infant dose. It's well under our 10% safety line. But then we get to Apixaban and Edoxaban, and the story changes.
Here is the red flag. With Apixaban, studies found that the potential relative infant dose could get as high as 21%. Remember our safety threshold? It's 10%. This is more than double. That significantly higher potential for infant exposure is exactly why Apixaban is not recommended. And for Edoxaban, well, the issue there is simpler. There's just no data. And no data means no go. We avoid it.
So let's bring this all home. You've got the science down. Now, what does this actually mean for you, for your exam, and most importantly, for your clients? This is the practical, need-to-know summary. Okay, when we're talking about oral anticoagulants, there is a very clear hierarchy. Warfarin is number one. It's the first choice. And why? Because of that long, proven track record of safety and those undetectable levels in infants. Now, if warfarin isn't an option for some reason, Rivaroxaban and Dabigatran are considered usable based on their pretty favorable profiles.
Now, no matter which compatible drug is chosen, we can add this simple layer of reassurance. It is so important to counsel the parent on what to watch for. Just simple things. Have them observe the baby's skin for any unusual bruising, check the diaper for any little sign of blood, and just keep an eye on their spit up. This is huge. It empowers them to be part of the safety plan.
And this brings us to the last and maybe the most important question of all. You know, knowing the science is one thing, but using it is everything. Your role isn't just to have the facts memorized, it's to translate them into confident advocacy, helping parents and their doctors make informed choices that protect both the parent's health and the breastfeeding relationship. So, how will you use this knowledge to become their best possible advocate?